have, at this moment, we have 88 participants, which is quite a lot. And we have here with us Una Farrell, that you know very well, from the Migraine Trust. I think it's time to start. I'm going to give you the floor, Una, and we can start because I'm sure we want to ask you, Professor Goss, with so many questions that it's important to have time enough to get them all.
Can I just ask a technical thing? Am I going to share my screen with you to do this? Is that how it's going to work?
I think that's the best way, because like this, you can press the button and go to next whenever you want.
Sure.
Sure. So we ask you, we share the screen with you, and you can share your presentation.
Okay.
So Una, please, can you start?
Okay, well, I just want to welcome everyone to the European Migraine and Headache Alliance's talk about migraine and COVID-19, which is something none of us in January would have imagined that we'd be here, that we'd be interacting in this way. So I want to thank you to everyone for coming along to this talk. I just want to introduce you to, first of all, Elena Ruiz de la Torre, who's the Executive Director of the European Migraine and Headache Alliance. So just little wave. And then to Professor Peter Ghostby, who is...
we cannot hear you very well. You need to put your micro closer to you.
Okay. Can you hear me better now?
Yes, a little bit.
I'll speak up. And Professor Peter Ghostby, who is the Professor of Neurology at King's College London. And it would be no exaggeration to say that he is the world's leading expert on migraine. So Peter is going to talk for about 15 to 20 minutes about COVID and migraine. And then there'll be a chance to ask questions at the end. And I will verbally ask the questions. So you can post your questions in the chat function on Zoom, and you can do it during the talk. So if there's something that comes up that you would like to ask, just post it as we go along, and then I will ask it. So I will just hand over to Peter, and thank you, Peter, for sparing the time to give us this very informative talk.
Thank you. I'm going to share my screen, and then get some, which says host disable participant screen sharing.
Okay, great.
So the host's going to need to
yes.
bless me.
Someone. So Paula?
Oh, it looks like it's enabled now. Okay. So please tell me if you can see the slides.
Yes.
Yes.
Clear?
Clear. We can see the slides very well.
And voice is clear? I don't sound like I'm underwater, as someone just said.
No, we can hear you. We can hear you, but Una, we couldn't hear you very well. You were like little bit echo.
Okay.
Well, thank you for asking me to speak. I'm sorry if the time zone thing got a little bit messy. I'm as was said, I'm interested in headache disorders. I was given some specific marching orders, you might say, from the organisers about topics to cover with regard to migraine and COVID-19, and I'll slip through those in a second. I was looking, it's a fluid space, and I was looking at some of these things just yesterday evening. I thought it was worth just pausing for a moment and acknowledging the fact that more than 1 million people are dead worldwide from this. So everyone understands it's serious, but that's like, it's just almost unspeakable that in 2020, for all the cleverness of humanity, a virus comes along and 1 million people are dead. It's extraordinary to me. So it's almost, I don't know if there are useful words, but if anyone on the call has had anything been involved in that, my sympathy to you. Death is never a good thing, and particularly when it in the ways that it's happening. Little map of Europe. This is from one of the EU sites. I gather the darker colours are worse and lighter colours aren't better. So it's easy to see that this is a pan-European thing. There's a little map with nothing in the middle of it there. I don't know how lucky they've been. Maybe they're not reporting it. This is a human problem. It's not a UK problem or anything like it. So I was asked to talk around some specific things, and I was given a sort of set of outline questions. And what I thought I'd do is try and break them up a little bit, and because I mean, forgive me, but I like this kind of organisation and structure. Anyone who's ever spoken to me will understand that that's just the way my mind thinks. So I've thought about this in two ways, and talk about how COVID-19 might affect migraine, and that's around frequency and severity and onset issues, and then how COVID-19 might affect migraine treatment, and there are some specific interesting issues around that. And within that, I was given also some specific questions to try and get around in terms of how COVID-19 interacts with migraine. So let's be good. The first thing I thought I'd talk about is the direct effects. I'll say at the outset that this is a work in progress. The whole thing is a work in progress. It's very clear that with the fluidity of the situation, ultimately, all of the things I put on here are going to require more clarification. Some are more than others. I think some we've got some factual basis for, but there's a lot. This is a very fluid situation, and if some of what I say turns out to be off base, some of it will be wrong, and some of it will be simply because we don't have enough information to be dogmatic. So on, excuse me, on the way that that COVID-19 and headache and migraine might interact, I think we do have some things that have emerged already from the literature. You notice it's all in 2020. So we saw from the very earliest experience of the reports from China, and this is a report this is data from January. The census was end of January 2020, 1,000 patients from hospitals. So already we're talking about the more severe end of the COVID spectrum because they end up in hospitals. And what they saw was 13.5% of patients with COVID presenting with headache. Most people, if you're a headache interested person, Patricia Pozo-Rosic in Barcelona would tell you, who's worked on the front line with COVID, would tell you that if you're a headache neurologist and you're interested, that number will be higher because you ask different questions. It's just a little bit of an approach. In any rate, the first headline was about this 13.5%. And interestingly enough, they looked at it in relation to severity, and severity of disease, meaning in the early stages, did you die or not, ultimately, didn't actually, wasn't associated with the amount of headache. At the start, it's completely unsurprising that the SARS-CoV-2 will produce headache in susceptible people, simply because if you took any upper respiratory tract pathogen or lung pathogen and you looked at symptomatology, you will find headache. Because if you disturb the physiology, the way the brain and the body is functioning, whatever you do, whether you do it with an infection or a drug or you just beat someone over the head, you'll get a proportion of headache. So that doesn't surprise me at all. Now, if you go from general medicine, which is all physicians, and that's really a lot of respiratory, breathing physicians, then you talk about the early experience in neurology. So a census data in February 2020. Now, this again is from COVID-19 care centers in China. So it's a little bit focused down to people who are, again, more severe, 214. Interestingly, they saw in all patients in this centre, about 13.1%. Pretty much what you saw of the other number. They report a little bit more, 17% for the more severe end of the spectrum. Hard to know what to do with that. It's 200 compared to 1,000. So you're getting an impression that in that kind of range, maybe nudging into 15% or so of people with COVID are going to have some sort of headache problem. Now, if you go from neurology, interested in all things neurological, down to headache medicine people, you start to get a different perception. It's the April 2020, a Spanish group, and they had a lot of COVID, so they've got a lot of experience with it. Looking at healthcare professionals who were COVID-19 positive, and again, I'll emphasise all of this as people who are COVID-19 positive, and we don't really have a clue of those who are positive with milder symptoms or who have the disorder with milder symptoms, never got tested, what's going on. So everything I show you will be an underestimate for sure. At any rate, they asked about the headache presentation in 100 healthcare professionals and said, okay, if you had headache, what pre-existing headache type did you have? 18% had migraine, 7% tension type headache, and one of them had cluster headache. And that's probably in line simply with a population thing. If you said how many people have migraine in this kind of age group in Spain, and you said 15, 16, 18, 20%, no one would be surprised by that. So what this suggests is that the background emergence of a type of headache is a reflection of how many people there are in the population to get it. Interestingly, the headache presented after fever. I'm not sure that's been something that's been repeated. And then some more headache medicine experience, again from our Spanish colleagues, April of 2020, hospitalised cases, so again the more severe end, and they were looking for whether there was anything that in this group of people with headache who could pick out a bad outcome. Answer was that didn't find anything. They did find 60% had some prior headache history, and again, look at the migraine number, about 16%. So it looks to me very much like in where this is coming to. If you think of the general medicine group as an underestimated, and as you get to the headache medicine people, a little bit more accurate in getting the history, and many of you listening will have had the experience of what it's like to have someone ask you about the problem who doesn't know what they're talking about, well, knows less, and someone who knows a bit more, it's a different experience. So it looks to me like the numbers are pretty much reflective of the population. So what's COVID doing to migraine? Well, it's bringing out the migraine biology, if you like. I don't see anything in the literature that suggests that COVID is making people who didn't have migraine biology suddenly have migraine biology. With that said, there will no doubt be some people, when we've seen a couple, who will have the COVID infection and their latent biology, so not manifest, will be flicked on by it, and they'll get this new daily persistent headache behaviour, if you like, and we could discuss that if people are interested. So there are some social. So the direct effects of SARS seem to me to be to take migraine biology, what you're born with, and express it or aggravate it, but not from a symptom point of view, really change it in its core. Now, if you look at some of the other specific questions I was asked about, it's confinement to home. There's an interesting, that's a sort of interesting problem. Let me go back here first. So it produces a couple of things. There's a social isolation aspect to that. I've talked to actually as many people who said that there's some element of reduced stress, not dealing, and I think it's a little bit where you are. If you're in London and you got the grief and aggravation of just getting across a road with some delivery bicycle trying to run you over, versus getting to the bus because the bus is about to leave, getting in some sort of queue or missing a tube train, or the ordinary trip. Sorry about the cough. The ordinary trip to work can be a pain in the behind. So I think that there are people, and I've spoken to them, who found the reducing and making more predictable the life is actually a good idea, and they've found it helpful. Not everybody. On the other side of it, it can be very socially isolating, particularly when we were right in the lockdown, and that takes its toll, you might say, on individuals. So I don't think there's a universal effect of the COVID pandemic on migraine in this kind of in the sense of what happens to you. I mean, it obviously depends on the sort of home that you have. If you have space to move about, that's great. If you don't have space and you have the kids home from school and they're trying to do something and you've got it, they're asking you questions here, there, and everywhere, and you're trying to get other things done and operate your life normally, terrible. If social isolation means a little bit less of the daily grief, maybe not so bad. It's a very variable feast. Is the home office a problem? Depends on whether your office is a problem to start with. There are many people who are not enamored of the situation they find themselves in the office, be it social or physical, flickering lights, all the sort of things you can't control, because a nice thing about being at home is you have a little bit more influence over the environment that you're in. All of that said, if you've got somewhere where you can sit in an office, as I can do, then that's quite nice. If you don't have anywhere and you have to put your computer on the kitchen table and then have the problem of competing with bandwidth. I mean, I've been on calls with colleagues who have to get their children to stop playing online games while to make any sense of what's going on. And then there's the invariable technical challenges of getting used to these new ways of working. And we just had a nice example of that as we got started. And, you know, that can be a little bit stressful, depends on how you take it. If you take it in your stride, like missing the bus from time to time, well, it is, as I say, what it is, more famously. What's happening with triggers? I saw some interesting data, and this is is maybe the wrong word to use, but reports that social media use has really skyrocketed in the COVID period. Is that good or bad? My daughter tells me I don't really, I'm in the wrong generation to even comment about social media things, and I'm more or less clueless on the subject. So I'm going to try and restrain myself to know whether that's good or bad. I'm kind of in betwixt and between social media. So I think there are people who, if you're a social media influencer, I'm sure it's really cool that there are more people looking at you. If you're a person who's feels uncomfortable on social media, I'm sure it's worse. And if you simply find your time sucked up, maybe that's a pain. I think that's an open question. It's indisputable that there's more use in terms of, you can see the consumption of bandwidth, and what the implication for that is for migraine is a more complex thing. I alluded to the issue of triggers in the controlled environment earlier on. So because I'm become very interested in the last 7 years or so in the question of how triggers interact with migraine symptoms, I'm in two minds about this, and I'll just show you a piece of data because I can't resist it, that goes to this. We were looking at a study, Nazia Karzan led this, about the so-called premonitory symptoms of migraine. Now, these are the things that happen before the pain sets in. And the official definition, for what that's worth, are the symptoms that precede or forewarn the attack. It can happen for many, many hours. You can divide them into groups, the things that happen in what's called the higher centers, thinking areas. So tiredness, concentration problems, or mood change. Yes, it's not your fault that sometimes you get a little bit stroppy before the attack. It's actually driven from the brain. Neck discomfort, and what we call homeostatic things. So these are things where the brain is regulating whether you eat, whether you pass urine or not, whether you need to sleep. Yawning is a manifestation of the biology of that. And when you think about it, a lot of really important things that the body does, you don't really you don't really plan them out. You don't have to get to do them. And they're these homeostatic things. And what we looked at was asking patients about triggers that they report. So tell us things that trigger your attacks, and then tabulating the premonitory symptoms in the same patient. So a good example is this relaxation from stress. I'm sure some of you listening would say, if I said to you, well, do you get your attacks sometimes when you feel relaxed from stress? You say yes. If you ask about feelings just before the attack, then elation is reported, and the agreement is about 90%. If you look at something like physical exertion, too much over-exercise, over-activity turn your attacks on. Well, yes. Movement sensitivity, as in the pain, you can aggravate head pain or get the discomfort by shaking your head about. There's an 80% agreement. Meal skipping is an interesting one. If I skip my meals, I get an attack. Okay. In the period just before the pain starts, hunger, cravings, and tummy discomfort is very common. It's an 80% agreement. So some of what's perceived as a trigger is this early form of the attack, the premonitory phase of the attack. I'm not suggesting all triggers are that. Don't get me wrong, but it's quite complex. If you buy into the idea that some of them are, then you clearly can't manipulate the brain's behavior early in the attack by altering your behavior, because the brain is driving the behavior. It's a manifestation. So it makes the whole trigger thing complex and can make it very frustrating. So bottom line of that is I think that whether being at home is a good or a bad thing, that's going to be an open question in terms of triggers. Let me turn to a couple of treatment things. One of the ones that got people really mega excited months ago was this question: if anyone's on candesartan. There are 2 randomized controlled trials. NICE has said it's okay. It doesn't have an indication because it was a blood pressure drug and got into migraine afterwards. So I quite like it. I don't like it. I mean, I like prescribing it, let's put it that way. Because once a day dose, you don't tend to put on weight. It doesn't make you go silly the way some of the drugs do. Okay. So the problem immediately, people jumped on this. Candesartan blocks a receptor, an area in the body, a protein in the body called an angiotensin receptor. So it's called an angiotensin receptor blocker because it blocks it. And there's 2, 1 and 2. So it blocks the first one. So it's called an angiotensin receptor 1 blocker. Okay, that's fine and dandy. Now, it's possible. There was a literature that suggested that if you block that receptor, that would in turn increase something called an angiotensin converting enzyme, which unsurprisingly converts a angiotensin, the precursor, into angiotensin, let's put it that way. And that would, because you increase the expression of that, you would increase SARS-2 entry into cells. So that was the speculation. And the idea is that here's the angiotensin 1 receptor, here's the candesartan, and if you block this, you have more angiotensin, which is coming around here to another receptor. And because there's more, this enzyme might be increased. That was the idea. It turns out to be just not a thing. The issue is what's called confounding. So in the data, the people who tend to be on candesartan had cardiovascular disease. And what's clear is it's the cardiovascular disease, which is the thing driving the COVID problem, not the candesartan. So it's an interesting idea. You can see the sort of thing academics love to do, draw little pictures and run around the houses with these very complex names. Bottom line is that the problem is if you have comorbidity for COVID, it's not a problem with candesartan at all, if anyone's had to have that discussion. And then the last one, I was asked the question specifically to address if you have bad migraine or cluster, should you go to a hospital or go to the accident and emergency? Spoiler alert, answer is no. And there's 2 reasons why I say that. The first one is, this is a lot of words. What it is the current definition of migraine without aura, the classic what's called International Classification of Headache Disorders definition. And I'll point out a few things about it, which you already know, anyone listening, that the pain can be quite bad, that it can be made worse by moving about, that you can have nausea and you're sensitive to light and sound. Now, if any hospital or emergency room you go to is noisy, like sound sensitivity, is bright, so it's just fluorescent lights everywhere, light sensitivity, they're usually pretty smelly in some sort of way, I have to say. I mean, I'm not trying to diss them or anything, but it's not a pleasant place, nausea. And they move you about, aggravation with activity. It seems to me like accident emergency centres are kind of non-headache area, if I could put it that way. So from a sort of fundamentally, it's a bad place to be. Secondly, during the pandemic, sick people are in hospitals. So going to a place where there are sick people is sort of like what it says on the jar, not a great idea. The problem with that, with the thought, it says, and it's on us, meaning on your physicians, to make sure that you not only have a treatment for your attack, but you have some sort of rescue therapy. Because almost invariably, someone will find that, once I say this, that's why I'm going to say almost, someone will find an exception, I'm fine with that. But in the generality of things, there's almost nothing useful that accident emergencies and emergency rooms can do that you couldn't have pre-planned to do already yourself at home without having to have more movement, nausea, light and sound sensitivity. So it seems to me like the job of the physician is to provide a therapy and provide also a backup for that that's at least as good. And I think because you can lay down and stay away from the place, probably better than going to an emergency room. You know, that said, the emergency rooms are in the UK and they're open for business. It's not like I'm suggesting that they're not. I'm simply putting it to you that going there is a failure on behalf of us because we're not giving you the tools that you have at home. So does COVID change migraine? I think it probably doesn't change migraine. Does it amplify it? Probably. Is staying home a good thing? Depends on your home. Is the home office worse or better than your office? Depends on your office. Do you think it can help you modify triggers? Well, you can control your environment. For some of those things, it won't make any difference. Do you need to change your treatments? You need to get the best possible treatment for your attack so that if you have the best possible treatment, you can avoid the hurly-burly that currently is our accident and emergency room. I'm going to stop there and happily take any questions, and I'll turn the share off and hold hand control back to whoever I'm handing control back to.
Thank you very much, Peter. That was really, really interesting, particularly about the triggers, because it's something that we can all understand and try and manage ourselves. So for you to share what you're learning as you go along is very useful to us. Can I just check, is the sound okay? Can you hear me okay now?
Yeah.
Yeah.
Okay, that's good. Okay, so
I'm going to say that, let me say, we wouldn't have got anywhere with all the patients who've helped us with that, and we wouldn't have got anywhere if the Migraine Trust hadn't sponsored the Fellowship of Nazia Carson, who did the work. So I'm going to say straight up that the reason I can give you insights is because patients, and particularly the Migraine Trust, is interested in finding out about the disorder. So if you want to find out about interesting things about migraine, look on the Migraine Trust website. And you know, I'm a trustee of the trust, so it's kind of naughty to say that, but I'm going to say it anyway because it's true.
It's true, because we really are a community. You know, we've got Peter, who's the leading specialist in migraine.
Right, Una, we have 95 participants now, and maybe they don't know what Migraine Trust is. So can you, in few words, say what Migraine Trust is? Because that's a really, really, really important information.
Okay. Well, we are a migraine charity. We've been operating for 55 years, and we do three main things. We fund and promote research. So we fund fellowships, PhDs. We have the Migraine Trust International Symposium that takes place every 2 years. And it was actually due to take place this September at the Hilton Hotel in London. But fortunately, although it had to be the physical event had to be cancelled, it's still taking place next week virtually. And I'm going to actually plug, we have an event, a public session on the afternoon of Sunday, the 11th of October. It's a free event to come along. Peter will be speaking at it with a range of other migraine experts. So please go to our website where you can register for free. We also have support services. We give information and support about migraine. So if you're struggling with migraine at work, or if you have a child who's struggling with migraine at school, we can help with that. We can also give information about symptoms, about treatments. And then also we work to raise awareness of migraine to increase understanding of it in the workplace, in the healthcare system. And we're working on a big project at the moment called The State of the Migraine Nation, to truly understand the care that people are receiving throughout the country, and we'll be launching campaigns based on that. So thank you. But the thing is, it's a community. So there's Migraine Trust, we're a charity, and the European Migraine Headache Alliance is a charity. We have experts, the world's leading expert, Professor Peter Goadsby. He also mentioned Nazia, who is an amazing researcher, who's vital to us. But also the most important people are the people with migraine and their friends and family who take part in the research, who support it, and I get migraine myself, I know Elena does. So it's a very strong community, but we all need to work together, and that's why it's wonderful that there's over 100 people taking part in this. So that's enough of that. Anyhow, I'll go. There's some really interesting questions that have come through, and the first one is from Irina Smelzy, who asked, do people with chronic migraine or migraine, are they at any risk, from what we know so far, of more severe COVID as a result of their migraine?
No.
Okay.
Well, I mean, if it's a complex answer, I'll make it complex, but, I can babble around the topic, but the answer's no. Your migraine may worsen, but otherwise you're not at risk of more severe COVID, thank the Lord.
Well, that's a nice, succinct and very reassuring answer. So thank you. Then Azul DePaul has asked, well, you had mentioned about not going to A&E, and Azul had a quite bad cycle of migraines in August with the weather, when we have quite thundery weather. So her GP wasn't very helpful. So what would you suggest for someone who is struggling with chronic migraine and trying to break the cycle? Where should they go?
Yeah, so, I mean, I suggested it because I think that going to A&E is a marker of failure of management, because there's nothing, as truly, for most people, there's virtually nothing the A&E is going to do that you can't already do, and some of what they do is not going to be useful anyway. So, the problem, difficult migraine, chronic migraine, is probably better off looked after by a neurologist or headache medicine people. So now's the time to put some groundwork into working out someone locally. The Trust has lists of the clinics to make sure that you get on the list and eventually see someone in the clinic to make a plan. And the important thing is to have a plan for what you do and a plan for what the rescue is. So they mentioned non-steroidals. The rescue might be what are called the triptan drugs, like sumatriptan and its friends. The rescue, if a triptan doesn't work, may be using a different formulation because it's not absorbed. So intranasal zolmitriptan. The rescue may be having on hand the sumatriptan injection, because if you're not absorbing anything and throwing up and so forth, one way to get around that is the auto injector. And you don't have to use it every week, and you may only use it once or twice a year, but that's an example of planning. And then you may change, there are other ways of doing this. You may, for example, if there's too much upper symptom nausea and so forth, suppositories are a way of dealing with things. Not the most necessarily culturally friendly way of doing it, but one has to be pragmatic in a difficult situation. Having something for nausea on hand, domperidone's useful. It's relatively easy to get prochlorperazine. There's a drug called ondansetron. There are a range of nausea drugs, because when you go to the accident emergency, they're going to diddle you around, so things will get worse for a while. The advantage of treating at home is you can treat straight away. In the A&E, you're not going to be first on the queue unless you're holding your chest if you're at my age, you're a man and you're holding your chest, they might take you to the front of the queue. But you know what I mean? So earlier is better. So something for the pain, something specifically for the nausea. There's no one right answer, but there's many ways to escalate therapy up to and including injecting yourself, all done at home, all medicines that are safe, and none of them require going anywhere, and none of them have the delay that's built into going there, because time is suffering. Time is just, you know, it's time out of your life, as Elaine has often said to me. So sooner is better, and sooner is actually more efficient in terms of getting a good response. So, I mean, so the time to make the plan is when you're well. Because when you're well, a little bit, you can have the conversation. Making a plan in the middle of a storm is an excellent way to get very wet.
Okay, thank you for that. There's a question from Polly Rose. So we're starting to hear of this thing called long COVID, where someone's COVID lasts more than 2 weeks. So it's not fatal, but there's a range of other symptoms. Is there any evidence that you've heard of worsened migraine as a result of long COVID?
Yeah, we've heard that, but that's not specific to COVID. That's long anything you want, whatever the infection or other physiology. The thing is that the migraine brain likes stability. It doesn't like to be shaken about. It doesn't like changes. So if you have disturbed what's called physiology, the way the body's working, over a period of time, as you'll have with if COVID and the response takes on for a period of time, that will disturb the underlying migrainousness, if I could say it that way. So you would predict that that will happen, and we've seen that happen, and it will happen. And there's what you do about the COVID-ness, and then there's what you might do about the migraine. So I do think that's a thing.
Okay, thank you. And I just want to mention, Anne Cobell has just posted a comment saying that she's had permanent headache and migraine since she got COVID on the 30th of March. She said it's nothing like her previous migraine or headache, and it's been very difficult to cope with. So,
yeah, well, in the general terms, I edged up to that towards the end. If there's a group of headache disorders that are called new daily persistent headache, because they're new daily and persistent, and there's headaches, like it says on the jar, and they're a group of things. They're not one thing, and they're caused by, they come from different places, and some of them are migraine that's turned on. And because it's turned on, it behaves a little bit differently, but the biology has a lot of similarities. So we have started to see people who have their this headache switched on. That's not a new phenomenon. New daily persistent headache's been reported for 40 years or there and thereabouts. And people, because it's never really received the attention that's appropriate, it's hard to be too dogmatic about it. But the largest group we see are people who've got migraine biology, so they're the predisposition, and then whatever happens with the process, be it a blow to the head, for example, be it an infection. I've seen it with other meningitis, with viral meningitis, with even bacterial meningitis. I've seen it with medicines. It turns itself on. So what the question is asking about is probably that phenomenon. And that requires, that's usually pretty tricky to treat, and we'll need to go at least to the neurologist or headache person. And again, finding one of the headache interested clinics is a really good place to start, because they'll know exactly what you're talking about.
Okay, thank you. And then Diane Kingston, so she posted saying that she had been taking Erenumab, 70 milligrams, which you obviously know very well, for 16 months. But her migraine has worsened since March. And she's just asking what should she be doing?
Yeah. Migraine cycles. I wonder if I can. The beauty of this sort of technology is sometimes. I'm going to try and find a picture to show you what I mean. But the migraine cycles. So if you don't make any change, things will very often vary. because that's the natural biology of the disorder. So, you know, many people would hear what was just said and they would say, well, the Arenumab is wearing off. Okay, you could say that. It wouldn't be the first thing I would think of. I'm going to show you a picture to make the point. And it's not going to be terribly elegant, but nevertheless, let's not worry about elegance for the moment. There's the picture. So I hope you can see the picture I'm trying to show you, which is these lines each represent an individual trajectory. Look at the years 2005 to 2009 of a person's monthly migraine days. Someone going from 4 to 10 down to nothing. These are moving around. So treated or untreated, migraine has these big cycles. Look at this cycle is happening over, if you look at it, it's taking what, 4 years to cycle, so to speak. So I just want to make the point that sometimes when you see change in migraine, it's not that it's not that drugs wear off. It's that the disorder changes itself. And of course, I mean that sometimes we treat people and they get better, and it's not because of the drugs at all or anything we do. It's because they cycle to get better. I'm always happy when they get better, and I'm happy to take responsibility for it. But I'm not stupid enough to think I'm always the cause of it. So perhaps the Arenumab is having the same effect, but the disorder's changing. Or perhaps the Arenumab's not working as effectively. That I can't tell it on an individual basis, but I can tell you both things are certainly true. I generally speaking I try not to do anything for as long as I can, 3-4 months, to see whether it is a cycling phenomenon or not. Because the problem with doing something is if you do something while you're at the top and you do it and the person's going to improve any rate, you think it's what you did. But you kind of then lose the plot of actually what the beneficial thing is. So when you get a worsening, you've got a couple of choices. You can leave the basic treatment and try and deal with the attacks that come, or you can add something, or you can increase the dose. Now, many people would double the Arenumab dose from 70 to 140. I wouldn't stand in the way of that. And if the person got better, I would say great. But I wouldn't get carried away with the idea that necessarily because you make the change, that the change causes the improvement or even indeed the worsening. So it's a sort of thing if you can be patient, it's useful because then you find out things about your condition. Because what I'm telling you is generic stuff that it's true because there's data, but it's not about you. One of the great things about an individual working with someone who's interested is you can start to understand what your problem's doing and understand what changes need to be made in you instead of taking averages from population. So I encourage people to, where it's possible, and I know it's difficult because it's it's a dreadful problem, but the more you know about your own problem, the more you can begin to, with a partnership with a sensible physician, you can start to really control it. We have to get away from treating everyone like they're all on the same bus. And okay, we're all going to the same place. Even if you don't want to go there, you get on the same bus. You know, we need a much more, I don't want to sound political, I don't want to say anything people will be irritated by, but it's kind of more of an Uber style of doing things where you get in the thing and you go where you want to go, in the way you want to go, instead of going in a big bus. And I'm not trying to say anything political about anything, but just, I think I've spent too much time being worried about political correctness.
Thank you.
I hope that's helpful.
That is, and there's moving on, we have another question about CGRP. So Mick Van Burn asked, are you more susceptible to COVID-19 if you take CGRP medication? Does it affect your immune system?
That's a really good question. And the answer is no. No, absolutely not. And, you know, and that's not just a matter of opinion. I'm just going to show you why you shouldn't have to believe what someone says, particularly if they can show you why this is the case. So I'm going to show you why. It's a little bit tricky, but bear with it, why this is the case. So on this slide, you see these are these monoclonal antibodies. Now on the right side of the slide, this little green and red thing, I hope you're seeing it, because I can only see it. This is what an antibody looks like. The business end is the green bit up here, And the bit that gets broken down, mediates how it gets broken down, is a red bit. Now in the middle is where it interacts with the immune system. So what's happened with all of these antibodies is the way the structure of this area has been engineered so it doesn't interact with the immune system. A good example here, if you change 3 of the amino acids, the constituents of this cis part here that interacts with the immune system, you go from an interaction with the immune system to absolutely nothing. That's actually the molecular change that some people at Cambridge worked out that's been incorporated into, for example, fremonizumab, just to make a very, very concrete statement. And you can see for yourself that that's just nothing. It doesn't interact with the immune cells in comparison to when these things are in their normal state, when they do. So you interact with the CGRP up here, the useful bit, but these molecules don't interact with the immune system because they've been designed like that. So they're called immunopharmacology, as in taking something the monoclonal antibody, derivative of the immune system, interacting with drug targets, receptors, and the things that bind to receptors. But for most antibodies up to this time would use that immune area to have their action. So they're typically been immune modulators, changing the immune system. And these antibodies don't do that. And the reason they don't do that is that's been worked out, and specifically the molecular people have changed those areas. Long-winded, but important that you understand that the reason I say no, not possible, is because it's been engineered out. It's really the science of it's really really very cool, and it doesn't interact with other antibodies either, which is cool. The system is very nice. So no, anyone on these antibodies is not at any risk of any sort of infection of any description, full stop, new paragraph, because we know the biology. That's what investing in research gives you. It gives you more than an answer. It gives you a rationale for the answer.
Thank you, Peter. There's a question from Gabriela Santiago. So if London goes into lockdown again, which it may or may not, will patients still be able to access treatments in the hospital?
Oh, you're asking me as though I have any influence on hospital policy. I don't even know who does. That's going to be very complex. What we were allowed to do, and it depends on the degree to which things get worse. But let's take the worst case analysis. It goes back to like it was in April. We had to switch entirely, and we've had to stay with entirely telehealth, as they say, approaches. We don't do any in-person consulting. And part of that is actually simple, dumb stuff like waiting rooms. If you've ever been in an NHS waiting room, you're lucky if you're not sitting in someone else's lap. It's so crowded. Less alone being worried about social distancing in an NHS waiting room is getting your own seat. So that's just not a thing. It's just not a thing. So that's the telehealth thing is taking over with that, and that has its limitations. In terms of therapies, we had to stop doing botulinum toxin injections because we actually, things like PPE and stuff, it's not really rocket science that you've got to be careful about, and pathways for doing that. And we were doing some of the occipital nerve blocks, particularly for patients with cluster headache who came into a bout. The rough test that our trust used was if we were doing something that would keep people from coming to the accident and emergency room, go ahead. That was a sort of, and I wouldn't want to be quoted on saying that too much. So will treatments be available? The medicines will be. A useful advantage of the monoclonal antibodies, if that's what the person's asking about, is they're delivered to your home. So, not having to come to the hospital is a good thing at that level. The botulinum toxin will get tricky because you have to have face-to-face. I think the PPE thing's gotten better, and it'll be a case-by-case basis. So I think there will be some constraint, but the constraint will be largely around things that are hands-on. And we're in a better place now in terms of the masks and the visors and just getting used to doing things in a different way. It won't be as easy, that's obvious. And now would be a good time to be thinking about things I was talking about before, as in what's your rescue plan? Don't worry about what you do every day or what you normally do. You have to have, have a discussion about what you do when it's a little abnormal. That's the one to have, because I think there will be constraints. I suspect they won't be quite as bad as they've been because we just got a little bit better at it.
Okay, well, thank you very much, Peter. And there are a few other questions, but some aren't about migraine. So what I would suggest is that people...
Well, I'm no good with epilepsy or stuff like that, though.
Well, that we have, the Migraine Trust has an information support service. So you can phone it. It's open from 10 a.m. to 4 p.m. on Tuesdays and Thursdays. So it'll be open at 10 a.m. tomorrow. And you can phone it on 0203 9510 150. So that number is on our website. And you can also email it any time. So we can answer all of those questions.
The other thing to say is that we'll have question and answer panel at the patient day. Exactly. During the Migraine Trust meeting. So, and just won't be me talking. I've corralled a whole lot of excellent people to talk, like global people to talk. So really try and come along to that. It'll be, if you haven't had your question answered, and I'm sorry you didn't, then there's plenty of opportunity to take questions on at that day and get a range of interesting views. I noticed Alina had a hand up.
Yes, because I wanted to say that you still have here 27 more questions to answer, and this is for the participants. It's 7 o'clock already in UK, 8 o'clock in Europe. I think it's a little bit late. We could keep Professor Gorby here for 2 or 3 more hours asking you questions. My suggestion is also we kept them all in a list. So we could maybe circulate them to you or send them to you, and if you have any to Migraine Trust and to you, and if you have any answer to them, you could answer to them, because I think it's going to be endless if we keep on this chat open, and everything is so interesting. I have copied all of them here in my lists here, and I won't be able to choose one because they are all so interesting, and I want to know all the answers too.
So they all will be answered. They all will be answered.
And I'm sorry to people if I've gone on a little bit about the answers, but for some of these things, I wanted to show you the facts behind the answers. You have to know in the migraine business, it's been treated like witchcraft for too long. And we're getting concrete answers to questions that you can believe in, so you can you can take them to the bank, as people say.
Thank you, Peter. Your answers were absolutely fantastic, and I mean I know a couple of my colleagues also logged on to this because they wanted to hear what you had to say, just so they could learn themselves more professionally about migraine. So thank you so much for sparing the time, because your time is so precious.
Thank you. The reason I do this, truly, I mean, it's hopeless. It's not good enough what we do, and I'm very pleased to do it. And I'm sorry I didn't get all the questions, but I'm really glad. It's really nice of people to log on and at this time, and I appreciate the opportunity to speak. If you can't communicate with people about what we're doing, it's just hopeless. So I thank you for the opportunity. Thanks, and thank you for everyone out there where it's not good enough. We even if working at home, we work every day to try and make things better for you. We do.
Thank you so much, Peter. And thank you also to Elena and the European Migraine Headache Alliance, because this is one of many talks that's taking place throughout Europe. And I'm pleased to announce that we're going to be holding another one in December. So please, sign up to our newsletter, follow us on social media, and you'll find out about it. I also want to just tell you about an amazing campaign called the Migraine Movement, which is being led. It's a global campaign that's being led by Elena and the European Migraine Headache Alliance, which the Migraine Trust is part of, and it's about improving the lives of people with migraine through increased understanding, awareness of migraine, better treatment, access to treatment. So if you go to the migrainemovement.com website to find out more about it, you'll find out information about its e-bulletin that you can sign up to. So please go to migrainemovement.com and you'll find out more about this amazing campaign. So I think that brings it to a close. So thank you, everyone. I hope you all have a lovely evening, and thank you, Peter, for sparing the time, Elena for organising this, and the whole EMHA team for organising this, and everybody for coming along. And your questions will be answered. And again, there'll be two more events. There's an event taking place on Sunday, the 11th of October. It's the public session of the Migraine Trust International Symposium, and the EMHA will be running another one of these events with us in December. So thank you, everybody, and I hope you have a lovely evening.
Thanks,
Thank you.
Una.
Thank you,
Thanks,
Peter.
Elena.
Thank you, Una. Thank
Pleasure.
you. Thanks to you too. Bye-bye.
Bye-bye.